Welcome to the Explainer. Today, we're stepping into the hot seat. Think of it as a high-stakes surgical viva, and we're breaking down the brand new 2024 guidelines for thyroid cancer.
Okay, let's just dive right in. The examiner leans forward and gives you this classic scenario. An ultrasound incidentally finds a small tumor in the thyroid. And then comes the big question. Doctor, what do you do? I'm telling you, your answer to this single question shows whether you're practicing medicine in the past or in 2024.
All right, so let's tackle our first dilemma. This is by far the most common situation you're going to face, the very low-risk tumor. And how you decide to manage this is a massive test of your clinical judgment and whether you're up on the latest evidence.
Now, if you want to score top marks, you've got to define your terms precisely. The examiner needs to see that you can accurately risk stratify your patient. So, according to the JAS guidelines, what are we talking about? A very low-risk papillary thyroid carcinoma is a small tumor, it's completely contained within the thyroid, and there's absolutely no evidence it's spread anywhere else. Simple as that.
So this is the crucial fork in the road. You've got two very different paths. You can go with active surveillance, which means you monitor things closely and only intervene if something changes, or you go with immediate surgery, the traditional approach of just taking it out right away. So what's the right call? Well, the 2024 guidelines give a very, very clear, evidence-based answer.
This number right here, this single number is the foundation for a massive shift in how we think. This comes from a huge study in Japan, and what it tells us is that the risk of one of these low-risk tumors growing in any meaningful way, we're talking just 3 millimeters, is only 5.5% over a whole decade. The vast majority of these cancers are just incredibly lazy. They don't do much.
And you can bet the examiner's next question will be, okay, doctor, so who are you more worried about? Who's more likely to progress? You need to have these predictors ready to go. We're talking about younger patients, say under 40, people with a high TSH level, men, and anyone whose tumor is already getting close to that 1 centimeter mark. These are the folks you watch just a little bit more carefully. And this is the data that really seals the deal. You have to weigh the risks versus the benefits. Jumping straight to surgery has a nearly 2% rate of serious complications, things like permanent nerve damage. Over 10 years, it costs 4 times as much. And get this, multiple studies show that the physical quality of life is often lower for the surgery group. So for the right patient, active surveillance isn't just safe, it's actually better. Okay, you've nailed the first question. The examiner seems happy, but now they're going to dial up the complexity. The next case they give you is a thyroid cancer that has actually grown into the windpipe, the trachea. This is a real test of your surgical decision-making. Your answer here has to be structured and logical. No scattered thoughts. This algorithm shows you're thinking like a consultant. Step 1 is always to figure out how deep the invasion is. If it's just on the surface, you can often get away with a shave excision, where you basically just peel the tumor off the trachea. But if that cancer is broken through into the airway, well, then it's a whole different ballgame. A full-thickness, complete resection is non-negotiable. Now, when it's deep, the examiner wants to know that you can talk intelligently about the two main surgical options. You have to compare them. A sleeve resection is where you take out a whole segment of the trachea and then sew the ends back together. It's great for function, but the complication rates at that connection can be pretty high. A window resection is a bit less demanding and might be better for an older patient, but it has a huge downside, a shockingly high rate of needing a permanent tracheostomy. We're talking up to 61% in some reports.
And here it is, the final challenge of your viva. This is the patient where the disease has gone beyond what a scalpel can fix. They have metastatic disease that no longer responds to radioactive iodine. This is where you have to prove you are absolutely on top of the fast-moving world of systemic therapy.
First, a nice, crisp definition. Refractory disease. What is it? It's that critical moment when the cancer cells lose their ability to take up iodine. All of a sudden, our most reliable systemic treatment is off the table, and we've got to pivot to a whole new strategy. This quote, straight from the guidelines, signals the huge shift in thinking. You must state this clearly. For advanced disease, genetic testing is now the standard of care. We are no longer treating all these cancers the same way. We are hunting for their specific molecular drivers and targeting them directly. And this table, this is the high-yield data you absolutely have to know. For a BRAF V600E mutation, especially in the super-aggressive anaplastic type, use dabrafenib plus trametinib and get a 56% response. You find a RET mutation in medullary cancer?
Selpercatinib gets you a 73% response. And for the rare NTRK fusion, larotrectinib gives an unbelievable 86% response rate. These aren't just small improvements. These are practice-changing breakthroughs.
Now, to really show your depth of knowledge, you can talk about the evolution of these drugs. We used to have what are called multi-kinase inhibitors, or MKIs. Think of them as shotguns. They hit a lot of targets, but also cause a lot of collateral damage, a lot of side effects. The new drugs are selective kinase inhibitors, SKIs. They're more like sniper rifles. They hit one specific target. The guidelines now say if you have a known driver mutation, you reach for the sniper rifle first. They work better and they're much better tolerated. So, you've handled all three dilemmas. To wrap up your Viva, the examiner wants a confident final summary. How do you pull all this complex information together into a clear, modern philosophy for managing thyroid cancer?
This is it, your modern thyroid cancer playbook. 4 key principles from the 2024 guidelines. Number 1, we de-escalate for low-risk disease. We embrace active surveillance. Number 2, when we have to escalate surgically, we are precise and tailor the operation to the problem. Number 3, for advanced disease, we individualize treatment based on genetic profiling. And number 4, we prioritize precision. If a target is there, we use a targeted therapy. This is how a modern thyroid cancer specialist thinks.
And you can leave them with this final provocative thought. It takes your answer beyond just the textbook and shows you're a clinician who's thinking about the future of oncology. Thank you so much for joining us on The Explainer.